Welcome to the December 2022 edition of the ASC eJournal presentation. Happy holidays to all, and don't worry, we will be back in January for another year of lively presentations in 2023. I'm Dr. Rezai, the chair of eJournal committee. I will be moderating this session and start with a brief introduction of our presenter, Dr. Hogan, who is a member of the eJournal committee. She has completed her residency and her fellowships in surgical pathology and cytopathology, all at Vanderbilt University Medical Center in Nashville, Tennessee. And currently she is practicing at, you guessed it, Vanderbilt University Medical Center in the Department of Cytopathology and Breast Pathology, where she also serves as the Associate Program Director of the APCP residency and the co-director of the Introduction to Surgical Pathology rotation. With all that, she has found the time to share with us an interesting, and I would add, timely and practical topic for her presentation. We are also grateful to have with us one of the authors of the article to be discussed, and Dr. Hogan will do the introduction shortly. Lastly, and in the spirit of an interactive presentation, we would encourage audience participation. Please use the question box to post your comments and questions, and we generally leave about 10 minutes at the end to address those. With that, Dr. Hogan, the virtual floor is yours.
Thank you so much for that kind introduction. And thank you all for joining today. I'm so excited to share this topic. This is something that I'm very passionate about in my own research. And it was just, as Dr. Rezia said, so timely with where we're at in our practices now. So today we'll be discussing cervical Papanicolaou tests in the female to male transgender population. Should the adequacy criteria be revised in this population, an institutional study? Of note, myself and Dr. Plummer both do not have any COI or relationship existing with respect to the content of this presentation. Dr. Plummer is here today with us. She's the first author on this paper. She completed her residency in anatomic and clinical pathology at the University of Minnesota in Minneapolis, Minnesota. While there, she completed advanced training in GI and liver pathology. She went on to complete cytopathology and hematopathology fellowships at the University of Kansas in Kansas City, Kansas. She's board certified in anatomic and clinical pathology and holds subspecialty board certificates in cytopathology and hematopathology. Dr. Plummer is passionate about proper lab utilization and the lab's role in quality patient care. We are so thankful to have you here today, and we'll be discussing some topics as we go through our presentation. So here's just a snapshot of the presentation. And I'd like to first go over some objectives. Our first objective is to develop a toolkit of understanding of the difficulties that transgender patients encounter in regards to screening practices, to recognize the effects of androgen therapy on cervical specimens, to be aware of the common pitfalls in patients with androgen therapy, and additionally, and most importantly, to consider a lower adequacy criteria for Pap smears in this very special patient cohort. And it wouldn't be a pathology presentation without starting with the case presentation. Of note, it's the holiday week and you are without your resident or your fellow, and you decide to take a peek at this slide. It's the first slide on the deck prior to matching up your patient information, number, and looking at the history on the requisition. So here on low power, you can see in part A, a preponderance of parabasal and basal cells. In B, there's an area showing transitional cell metaplasia. In C, a high power showing autolysis. We have our nice nuclei and cytoplasm discohesive there. And then in D, a high power image showing a nice reactive and reparative group of cells. So now, obviously, I think the title may give this presentation away, or this case presentation away, but what kind of patient would you expect this to be a Pap smear from? a 21-year-old with no prior PAP, a 65-year-old postmenopausal female with no history of ascus or greater, a 38-year-old with a history of LSIL, or a 21-year-old with symptoms of PID. And typically in the patients that we are presented, you're right, we would expect this to be from a postmenopausal patient. However, these examples actually are pictures from the paper and come from a patient with atrophy due to the male to female transgender patient who is on androgen therapy. And we'll talk a little bit about that later. First and foremost, to get everyone on the same ground, I wanted to talk about a little bit of definitions so that everything is very clear throughout the presentation. When referring to transgender patients, a trans man is a patient who is undergoing a female to male transition, or just simply someone who identifies with their gender identity in the masculine spectrum or of gender nonconformity. Male to female trans woman patients are assigned male sex at birth. However, their gender identity lies on the female spectrum or with gender nonconformity. Cisgender patients are patients whose gender identity corresponds with the sex registered for them at birth. So a cisgendered female is a female who identifies as female, and a cisgender male is a male who identifies as male. Now, patients undergo a variety of surgeries and gender-affirming therapies when they transition either from female to male or male to female. Female to male patients, which will be the patient population we discussed today, engage in a variety of masculinizing therapies and or gender-affirming surgeries. This variety of therapies would compose an entire webinar to talk about in themselves, so we won't go through them, but I would like to individually note a few of them. When discussing masculinizing hormones such as testosterone, these patients can undergo vaginal atrophy, and atrophy, as we know, can be inducing reduced cellularity, as we see in a few other different patient populations. Now, those undergoing transition can receive varying levels of these hormones depending on the desired outcome of the transition. So depending on whether they would like to just suppress secondary sex characteristics or undergo surgical transitions, they have a variety of different therapies. Additionally, patients may undergo hysterectomy to reduce the risk of endometrial cancer related to testosterone therapy. And additionally, these oftentimes can undergo supracervical hysterectomies, therefore presenting a continued need through cancer screening even after transition. Additionally, it is, as we had said, it is recommended that these patients do follow similar cervical screening cancer schedules to those cisgendered females. However, unfortunately, these patients tend to have lower rates of screening, and this can be very multifactorial. There can be decreased access due to care and insurance, insensitivity of healthcare providers, emotional distress during a physical exam, and it also can be very traumatic for these patients. Additionally, these patients can have up to a 10 times higher rate of unsatisfactory PAPs, which also can contribute to a lot of the trauma because the patients undergo physical discomfort and then they end up having to go ahead and be rescreened multiple times, leading to additional therapies, which may cause additional stress. This is one of the algorithms for the ASCCP risk management consensus guidelines for cervical cancer screening. And here you can see, and I'm sure you're all very familiar, that a patient with no HPV done, so a wide variety of age patients are seen in the transgender community. So if it's a younger patient who's not being co-tested and there's no HPV, if it's an unsatisfactory PAP, they recommend screening at 2 to 4 months. If it's again unsatisfactory, the patient would undergo colposcopy. So you can get into this significant loop of PAP procedure for these patients, and we want to see if we're able to go ahead and minimize any distress or physical discomfort. Apologies. The increased unsatisfactory rates have been identified within a few studies on transgender cohorts, so it's widely seen. And then one might even ask male to female screening. So it is noted by the ACOG in their 2021 guidelines that neovaginas created do not require routine cytologic screening. And prostate cancer screening for trans feminine individuals should follow the recommendations for cisgendered men. Okay, so we'll go ahead and get started talking about this study. Dr. Plummer and her colleagues used a translational research database using ICD-9 and ICD-10 codes for gender identity disorder in adolescents and adults. And the codes are as follows. Of these patients, those who underwent PAP tests were included. And of note, the pap smears were performed by clinicians in family medicine, internal medicine, and by OB/GYN outpatient clinics. And their exclusion criteria included patients under the age of 18, those who opted out of research endeavors, of course, male to female trans patients who were not on exogenous hormones. And so I think that's a very big thing to remember. All of the patients in this study were on androgens. Now, I wanted to go ahead and take a moment to ask Dr. Plummer a couple of questions about the study. Interestingly, it was worded in the paper that you went into the translational research database. Does your health record or requisition have a place for clinicians to indicate that a patient may be transgendered?
At the time of the study, so the recs themselves did not. So I got in touch with my colleagues at KU, and since doing the study, their recs have been updated to include a field where they can include whether the patient's on androgen therapy or not. Just makes sense because there's fields that you can say whether the patient is postmenopausal or postpartum. Absolutely. So it's the same field.
Awesome, awesome. And then how were you able to get the cohort from the study? I know you use the ICD-9 and ICD-10 codes, but it sounds like there's a special research database. How did that sort of play into it?
So ideally, had we had this information on our recs, it probably would have been easier for us to pull just using COPATH. But KU has this wonderful tool, and essentially there's a lot of red tape to get access because, as you can imagine, there's a ton of sensitive patient information in there. But you can use ICD-9 codes to search the entirety of the health system, and it will pull up every single patient that's been seen with one of those codes attached. Furthermore, you can whittle it down by those patients with certain procedures. So that ICD-9 code plus PAP test. So that's how I got my initial cohort, and then of course, as you mentioned, whittled it down thereafter. It was limited to though, because that doesn't tell you who has opted in and opted out. So for that initial cohort, I still had to go into the chart and write in their like front page demographics was whether they opt in or out. So.
Awesome. Well, I'm glad you were able to find such a robust number of patients to identify. Yeah, that's really excellent. And then does the health system that you did the study under have a particular transgender clinicians that you can easily spot on recs? I know sometimes that's something that I rely on with our patient cohort because we don't have any particular on the rec except the free text area to indicate that they're a transgender patient.
So as you mentioned before, the patients in the study cohort, I mean, they were seen by OB/GYN, family medicine, internal medicine, and all those physicians also see cisgendered patients. Since a lot of these patients were seen, so because this I think dates back to like 2013, KU now has a whole gender affirming center So that addresses
Wonderful.
everything from primary care to psychological needs to surgical needs, et cetera. So they may have added particular physicians who almost exclusively see these patients since then.
Awesome. Awesome. Okay, well, we'll go ahead and keep going. So under the material and methods, the search under the patient's history included relevant gynecologic history, duration of androgen therapy, and when the reports are reviewed, they took into account the Papanicolaou test results, the HPV test results, and relevant gynecologic surgical procedures. They used a chi-squared analysis, and the results of these tests were compared with those of an atrophic control group that consisted of postpartum and postmenopausal cisgendered women who had undergone Papanicolaou tests in 2019. And I think that was brilliant. I think that was a really great way to develop a control group for these patients. I don't know that I would have thought of that myself. So very, very astute idea. All the Papanicolaou tests were processed under the Hologic ThinPrep liquid-based PrEP system and interpreted via the Bethesda cervical cytology reporting system that was current at the time of the diagnosis. High-risk HPV DNA testing was performed on samples prior to 2017, used the Mayo Clinic laboratories as a lab-developed PCR, and then 2017 or later were performed using the Aptima HPV assay on the Panther system. All available cases from the female to male transgender group were reviewed for cytomorphologic features, and all slides were signed out, originally signed out as unsatisfactory, for evaluation, were due to low cellularity, but they were also re-reviewed for cellularity. And just to go back and talk about the HPV, did the Aptima or the Mayo Clinic break down the HPVs into 16 or 18, or was it just all high-risk HPVs together?
So the Aptima assay groups them all together. It detects 14 HPV, high-risk HPV strains, but it'll just say it's more of a yes or no. High risk was detected. The Mayo Clinic was a lab-developed test, and I honestly cannot remember if they pulled out 16 and 18. I know the one we use here at Methodist does. It's 16, 18 or other. So I can't say.
No worries, no worries. Ours is very similar at my institution, so it's just something that sparked just a quick question. And then going into the estimating total cellularity, this was obtained by performing a representative field cell counts that included the center of the preparation, and then the squamous and intermediate cells in 50 high power fields were counted and averaged. And then the average number of cells required to achieve a minimum cell concentration of 2 to 5,000 cells per preparation was calculated using the below formula, which was the number of cells required due to the minimum PrEP concentration over the area of PrEP and area of field present. And so for Dr. Plummer, did you have multiple individuals count an average to ensure that they were unsatisfactory? Was there just one individual who did it?
So if you include the cytotechs that initially screen these PAPs, there's at least 3 there. So for the study, I did the initial screening or the re-review, I should say, to determine cellularity. And then I handed them off to Dr. Fang, my program director, and she essentially checked my work. So I think in total, probably about 3 people looked at these.
Excellent. And then how many fields did you end up averaging on this slide?
I think it was 50 I wanted to do. So if you look in the Bethesda, they do offer that equation or way to do it.
Exactly.
So you know for your scope how many cells you need to be seeing on average. So I went across the center and tried to do 50 fields and 20x fields.
Excellent, excellent. Thank you so much for your input there. And then just going on to discuss the results, I think this was the part that really excited me. So the fact that you guys were able to get 71 female to male transgender patients in this study was very, very powerful to me. I think identifying with the ICD-9 and ICD-10 codes gave you a true advantage in that situation. So there were 77 associated Papanicolaou tests with this patient cohort. And they were collected again between the years of 2013 and 2020. Within the cisgender atrophic group, control group, there were 1,941 patients and 1,974 Papanicolaou tests. So for the female to male Pap smear data, 69% of the patients had a negative Pap, 5% had ascus, 1.3% had an L-cell Pap, 1.3% had atypical glandular cells, and 23.4% were unsatisfactory for evaluation. And of note, I think it was really important to mention that the duration of the androgen therapy within these patients was between 1 and 108 months. And the mean duration of these patients with unsat PAPs was 33.4 months. And I apologize, I got ahead of myself there. But to talk to Dr. Plummer, at the time of this study, when they were signing out these patients, did the institution have a way to indicate that the diagnosis was unsat potentially due to atrophy or just low cellularity in general?
So the way we signed them out, we do include a comment for atrophy or reason for unsatisfactory. Generally, it's unsat due to, and then insert whether that's obscuring inflammation, low cellularity, etc. And then we'll also include just a comment about atrophy. We don't really go into why there's atrophy. Like, we don't say atrophy due to.
Exactly. Okay, excellent. Thank you. And then additionally, I don't know, maybe it was because of my bias and I'm so new to signing out, but were you shocked at all that there were no Ask H's in this cohort, given that that could be sort of a common pitfall for people?
Yeah, okay, so I'm gonna be honest. At the time, no, I was not shocked, but I also wasn't really thinking about it. We have amazing cyto techs at KU. They're sharpshooters as far as what their diagnostic skills are. But now I'm in the same boat as you. I'm relatively new to like practice, and yeah, I am surprised there weren't more Ask H's.
Yeah, absolutely. And then I just wanted to go ahead and talk about, your data here with the androgen therapy data in comparison to other studies. Other studies that I was reading actually had an average testosterone use for patients of about 3 years as well. So I don't know if that's the sweet spot in between initiating a transition to prior to transition. But in another study that I had read, there was significantly higher rates of HSIL and unsat PAPs. It was 16% in that study, and we'll get into that a little bit later. And that was in a study that compared it to an atrophic cohort with cisgender women. And then additionally, in other studies, there's an HPV rate of about 20%, give or take a few percentage points on this study. And your study was about 18%. So I think there's maybe some consistencies in the data that help us to maybe help the patients make a really easy call on potentially to co-test even earlier, if possible, to help with their treatment and care prior to any sort of transition gender affirming therapies. Going to the results, I really like this first table. It kind of really laid out nicely where the patients were in comparison to your cisgender cohort. So obviously there was significantly more atrophic pap smears in the cisgender cohort, but the age ranges for the female to male trans patients were 18 to 57, and in the CGA cohort were 21 to 89. Average age was 28 in our FTM patients and 56 in the CGA, as we would expect more of that atrophic group. Median age in years is very similar to the others. And within that FTM group, Papanicolaou test associated with high-risk HPV testing is 35%. I'm thinking maybe, and I don't know if you have any insight, Dr. Plummer, but maybe that's just due to that being on the cusp of co-testing, and since you had that wide age range. And then it was 88% in the CGA patients. And then within the FTM patients, 18.5% were positive for HPV, and the CGA patients was approximately 9%.
Going back to that slide real quick.
Oh, yeah, sorry.
Yeah, I actually think that the PAP tests in the FTM group, that co-testing wasn't performed. If you look at the average age of that group, a lot of those patients were in their 20s, and the co-testing is not always done, and it's not required in your 20s. So I think that's why we got that mismatch there.
I completely agree. And then going on to the CGA control group, just to break down the different diagnoses here, again, an overwhelming majority were negative PAPs, approximately 4% ASCUS, 2% LSIL, and then less than 1% the following: ASC-H, HSIL, squamous cell carcinoma, AGC, adenocarcinoma, and small cell carcinoma. And then the unsat rate in this patient population was approximately 3%. Question for you, Dr. Plummer: were the significant diagnoses of the carcinomas confirmed on biopsy in this patient group?
I know for sure the small cell was, because one does not forget that.
Yes.
As for the others, I can't say, because I'm almost certain they probably did, because the institution was large enough. Essentially, if you got your screening there, you got your surgical care there as well.
Absolutely.
But because I was on my Cyto fellowship, I didn't necessarily see them.
For sure. It was more of a curiosity for me to ask that. And then within the CGA control group of the unsat samples, 56 were due to inadequate cellularity, 2 were due to obscuring inflammation, and 2 were due to a combination of obscuring inflammation and inadequate cellularity. And that just touches upon what we spoke about earlier, kind of indicating why, which is standard, of course, for reporting, but it also doesn't include, maybe that atrophy was a component of that. And so here we have your second table, which again just kind of compares our rates. And again, the most notable, the FTM patients had approximately 23.4%, and the CGA patients had about 3%. And again, pretty high rates of negative PAPs within these two patient cohorts. Additionally, I wanted to go ahead and talk about the bottom of this table. For these patients at the bottom with the positive HPV, and I'm sorry, this is our female to male patients' high-risk testing results. So the patients who were positive, of those 5, one of them did have LSIL and CIN1 on biopsy, and one of them was negative for a THBSO. Others who had AGUS or ASCUS or even unsat rates went on for THBSOs or an additional pap smear and had negative follow-up in that. Let's see. Additionally, for the patients with ASCUS, as noted, and positive HPV, one of them, I apologize. Here we go. This is the point I was trying to make here. The other 3 here had no HPV positive follow-up after that. We spoke about that. And then, okay, for the female to male unsat cases, 4 patients had follow-up gender affirming THBSO, as we saw on the table, all of which had no histopathologic abnormality, and then 5 with follow-up for Papanicolaou tests. Of those, the results for the follow-up, 3 were unsat, 1 was negative, and 1 was ascus. Okay, so this may be a silly question, Dr. Plummer, but for the patients who were at the top portion of the previous slide here, were these patients undergoing THBSO for their gender affirming therapy, or was it for other diagnoses? Was that indicated in their charts at all?
I think the overwhelming majority of them were having THBSO for gender affirmation. I think maybe 1 or 2 were for other non-neoplastic causes like fibroids, etc. None of them were for neoplastic issues.
Excellent, excellent. Okay. And then talking about the chi-square analysis, the proportion of the Papanicolaou tests that were unsatisfactory for evaluation differed significantly between the groups, with a p-value of less than 0.05, and then a proportion of Papanicolaou tests with associated positive high-risk HPV test results and Papanicolaou tests that resulted in epithelial abnormality did not differ significantly between the groups, with a p-value greater than 0.05. Of the 18 female to male unsatisfactory PAPs, again, due to scant cellularity as confirmed by the study group, 17 were available for review. The cellular concentrations ranged from 628.3 to 4,298.9 squamous and metaplastic cells per slide. 5 of the 17 cases had a cellular concentration of greater than 2,000, and none of the unsat Papanicolaou tests had an identifiable epithelial abnormality. And I was really glad that you guys chose to include the cellular concentrations for these. It kind of gives you a really wide range of, within that circle, what are we really seeing in these unsat cases? And at our institution, we tend to say it did not pass the test, but it's nice to see numbers associated with that. And then overall features, 68 of the 77 female to male cases available for review, 93% of them showed features encompassing atrophy, and they were identified within the thin prep slides reviewed. And again, going back to the image I showed earlier, those beautiful photos from the manuscript, you have these examples that you can see within pap smears. And so, as noted again, there was 81% of patients with parabasal or basal cells, 26% with autolysis, decreased cellularity in 31%, and 21% with transitional metaplasia. Inflammation and reparative changes noted in 41 and 34% of cases reviewed. Additionally, I wanted to ask Dr. Plummer, again, early in practice, I don't know that I've seen the transitional metaplasia in any of the transgender PAPs that I've seen, and we get quite a few due to our transgender clinics. Do you encounter it in daily practice, or is it something that you identified on the study, but you feel maybe rare in practice daily?
I definitely saw it in the study, but I mean, I was also
looking for it.
Yeah, I was looking for it. And honestly, since doing the study, I see it more regularly because I think I'm just tuned into it. I think our brain has a tendency to screen out things that aren't necessarily diagnostically important. I know for sure I've had at least one PEP at my current institution where these groups were flagged as reactive repair. And I'm like, oh no, that's transitional metaplasia.
I know. I'm looking forward to being back on pap smears in the new year and getting myself keyed in for it in hopes that I'm able to identify it and maybe put it in the teaching set for residents and fellows. So in the getting to the discussion of the paper, female to male trans patients often have lower rates of cervical screening. This has been seen, like we talked earlier, with different studies, and these patients are less likely to return for follow-up after an unsat pap test result. It's the exam, maybe it's nerves, maybe it's anxiety about finding something, or just the anxiety of going to a physician's office who may not understand the transition that they're going through. Additionally, of the female to male patients in this study with unsat pap rates, 50% did not have a follow-up pap test within the 2 to 4 month recommended interval. And again, that may be due to scared of having another procedure, not wanting to go to colposcopy, or possibly even being discriminated against. So it's something we need to be keyed in and aware of for this patient population. Although current Bethesda guidelines recommend that a minimum of 5,000 well-visualized, well-preserved squamous cells or squamous metaplastic cells be present on a liquid-based preparation to be considered accurate, allowances are given to other patient populations. Pap tests from patients who have received chemo or radiation therapy, have a surgically absent cervix, or postmenopausal induced atrophy are often not held to that same threshold, with lower degrees of cellularity being considered adequate or acceptable, based on the assumption that these are just lower cellularity specimens in general. And indeed, studies have shown adhering to strict adequacy criteria pertaining to specimen cellularity leads to high unsat rates. And moreover, the scientific evidence from which the 5,000 cell count threshold is relatively limited. So this is definitely something to take into consideration. Dr. Plummer, does the institution that you did the study under, and maybe even your own practice now, adhere to the strict guidelines for those special populations discussed, or does it tend to be attending specific, or what is your experience with that?
So I've not met a single cytotech or person that approaches a pap and says, I'm going to start counting. It's very, once we've done this for a while, you definitely get an impression of when you're going to have a questionable one. And it's then both the cytotechs here and the cytotechs at KU, if they get that vibe, like this might not be sat, it's then that they go into the rec, into the chart. Is this patient atrophic? Do they have a reason to be atrophic? If so, threshold is lowered, or they rerun the pap. Always another option.
Absolutely, absolutely. And then continuing on in the discussion, patients in this study showed atrophic changes similar to those seen in other atrophic groups, and that's been documented, I think, really well in other studies, and appreciate the beautiful images that you took for this manuscript. And then when compared with the CGA patients, the FTM patients were 7.8 times more likely to have unsat PAPs, in the 3% versus 23.4%. This again is also similar to other studies, and in other studies, the FTM patients had unsat rates between 6 to 13%. These studies and yours, of course, also attribute the levels of unsat to be due to lubricant, physical body changes induced by the testosterone therapy, and then provider-patient discomfort with the exam. The rates, additionally, the rates of epithelial abnormality within the FTM group in the study did not differ significantly from those seen in the CGA patients. And that's a really nice reassuring factor to see, similar to those detected in other studies that looked at pap tests results in the FTM transgender groups, and those rates were 6 to 30% having an epithelial abnormality. And again, I think a really big thing for us to all remember, particularly, if you're not looking at the rec before you look at the slide, atrophy in a young patient may be due to testosterone therapy, and we want to make sure that we can kind of look at that and address that if needed. And in your case here, we had 93% of patients on the androgen therapy with atrophy, as we see in that CGA group. So that, you know, gives us the question, why are they so different? Given that these patients have similar atrophic cytomorphologic findings, and given that the PAP tests, you know, are designated unsat due to scant cellularity, what is the big discrepancy between the unsat rates in these groups? And, you know, requisition forms that accompany PAP tests at our institution offer the option to select, you know, whether a patient is post-therapy, radiation or chemo, but don't necessarily offer, you know, things such as androgen therapy and other options. There are, as we discussed earlier, write-in options or maybe even more up-to-date things. But it may be that, you know, the FTM patients in this study were held to this, if they were held to the same maybe amended cellularity in those patients that are post-treatment or surgically absent cervix, that, you know, and you had mentioned in your study that 5 additional PAP smears would have been considered adequate, which would have reduced the unsat rate from 23 to about 17%. And that's not a huge jump, but it's a big enough jump to where maybe it's not having to bring these patients back for another PAP smear or even a colposcopy prior to gender-affirming therapies. Oh, and I apologize, I did get ahead of myself there. And then talking about in discussion the high-risk HPVs, the prevalence of high-risk HPV within the FTM group was 18.5%, and it was 8.9% in the CGA group for the age-matched general non-atrophic population. However, it wasn't significant by statistics. And so the median age for the FTM group, again, was 26 years old. And of those, the patient age range for those HPV tested were 24 to 51 with a median age of 30 years. When compared to population studies of the female patients in the United States in general, the prevalence of high-risk HPV among FTM patients in the study is similar. It's 18% versus a range of 5 to 24%. However, the prevalence of high-risk HPV in female-to-male trans patients in the study that we're discussing is significantly higher than that detected of FTM patients in other studies, the 18% versus maybe a range of 13 to 16 from some of the studies that I saw. The median age of the patients with, again, the FTM was 26. You know, when compared to the FTM groups, this studies was slightly higher, although I don't particularly think a 16 to 18% is that big of a jump, but definitely some food for thought. Transgender, in conclusion, just, you know, wrapping things up and this wonderful paper, transgender patients who receive androgen therapy have high rates of unsat PAPs. We've talked about this. Hopefully when you walk away from this, this is something that you recognize, and it's due to atrophy-induced reduced cellularity. The threshold of 2,000 cells should be something that maybe want to be considered in this patient population, or including them in that patient population of post-treatment and surgically absent cervix, given that we know the atrophy is induced by the testosterone therapy. So today, thank you all for tuning in. I hope that you are able to develop a toolkit of understanding of the difficulties that transgender patients encounter in regards to screening practices, to recognize the effects of androgen therapy on cervical specimens, atrophy, to be aware of the common pitfalls in patients with androgen therapy, and then to consider potentially a lower adequacy criteria for PAP smears in this patient cohort. Dr. Plummer, I just wanted to ask before I wrap things up, is there anything that you'd like to add or address, maybe that we didn't discuss, or anything that you find maybe another take-home message from this really important study?
I think only other thing I would like to add is, like, let's do more research. I think to establish this 2,000 cell threshold for this population, you need to, or we need to establish whether they are at higher risk for lesion of HPV. But as you said, I think one study had increased H cell rates, but I do wonder.
Yes.
Yeah,
Yes,
I do wonder what their N was, because you're going to get an increased rate if your N is not that high.
Exactly.
But yeah, if we can truly establish that this population is not at any higher risk than the general population, and moreover, the populations we already reduced thresholds for, then why are we putting them through these extra tests when they're going to be that much more uncomfortable for them? Or maybe change our practices. Maybe, I know we don't do co-testing up front for those under 30, but maybe for this population we should. We might be able to catch some unsats with positive HPV that can further dictate their treatment.
Yeah, absolutely. Thank you so much. And I completely agree. Just doing what's best and maybe helping guide and direct further and future practices for all of us. So with that, I'd like to give a special thanks to the ASC eJournal Committee. I'd like to also thank those of you on the webinar today that participated in the Twitter chat last night. I'd like to thank Joanne Jenkins, Dr. Rezia, Dr. Fang, and thank you again, Dr. Plummer, for being with us today. It's been an absolute pleasure working with you, tweeting with you last night, and talking about your excellent paper today. Again, this is a topic that I'm super passionate about, and a patient population that I think is super important to develop these studies and make sure that we are giving them the proper and best care, particularly during
She's frozen.
These difficult times in their lives during a transition where they have a lot of appointments and all to do. Maybe we can take an extra pap smear or a colposcopy off of that list of things to do.
And I thank you
so
for
with that, I'll
inviting
hand
me.
it over to see if there are any questions.
Very good.
Yes,
Thank
of course.
you both. This was great, very clear, and as I said, it's timely and very practical, because it's something that we're going to be looking at more and more, and it's good to be equipped with the knowledge that requires to deal with these cases. So that was very, very wonderful presentation, and you guys did it wonderfully. I don't see any questions in the question box, but people may just be getting their thoughts together, or it was just a wonderful presentation. Nobody has a question. But I do have something that I want to kind of, is a commentary, is not necessarily a question. As far as getting the history of the transgender population, it's wonderful that you were able, for the purpose of your research and your paper, to go through the ways to get that information in your hand. For day-to-day practice is not that easy and straightforward, as I'm sure you guys know it. And first of all, we're always left to our own devices as pathologists, so you kind of try to go through so many different channels to see if there is an information that would be helpful to you to do something. Even when I was seeing the gender affirming surgery specimens, I had to fight and get the I guess the sex assignment and the gender right on the paper, because there were so many changes during a very short time that nobody in the OR knew how to mark them, nobody knew how to do it, and then if they messed up the current gender or the current sex or the birth sex and all of those things, the patient's insurances would be getting denied for the surgery. So there was a lot of back and forth on those things. So I guess we have a lot to learn for that. And that would be great if we finally come to a somewhat a standardized fashion to kind of address the patients in a way that is known to the physicians who have to look at the cases of these patients, especially a pathologist, and but in a way that is respectful, and in a way that is not discriminatory, in a way that it's really real in a way. So I always had that question. So I was so I guess happily surprised the way that you were able to capture your patient population. And again, Dr. Hogan, you are in a center that has a clinic for transgender, so that's also makes it much easier to kind of gather the information accurately on these patients. But unfortunately,
It
that's not the
does.
case for all of us.
Well,
So
and
my
you know,
go ahead.
honestly, and I apologize, not all of our patients go to that clinic or are there right
Right.
away for their pap smears, and because they, they may be already within the OB/GYN system or the family med system. So I applaud Dr. Plummer and their group for doing the ICD-10, because otherwise, as you noted, it would almost be impossible to identify the patient population.
Exactly. But I have now I have a question. As you were, especially Dr. Plummer and also Dr. Hogan, I know that you have looked at this population, but have you picked up any clues that if you're looking at a PAP, there is something in the way that the cells are, the way that, the background is, something that would tell you, like, for example, when I'm not given the history of a patient with prostate cancer that has been treated before, I right away know that there are changes in the background that makes you feel that way. And then you call or you look up to the history, and then sure enough, the patient had it. And sometimes you have to dig harder because the patient didn't have a history of prostate cancer, but had a rectal cancer that got radiated for. So then you would see the same changes. So is there anything that you guys have seen that would help us to kind of be a little bit more, sure that, okay, well, maybe I should call, maybe I should get to this person's, physician to kind of get my information right and not to give them an ONSAT when they shouldn't necessarily get an ONSAT diagnosis?
I'll defer to Dr. Plummer first. She's seen them en masse together.
I mean, as a population for female to male transgender, I know the transitional cell metaplasia that you see, but I don't think it's necessarily unique to the population. I think it's just atrophy. So I wish I could say I saw something unique, but I didn't. It's just atrophy.
I kind of thought that I have the answer, but I kind of throw it out there just in case you guys kind of start looking at things and you're figuring out that, specifically if the androgen therapy will do something that, I know the answer is probably no, but I was just hoping.
No, and from what I saw, I'm sorry, go ahead.
Oh, I think she's touching on an important side note, though, because as a pathologist, depending on where you get your specimens, you don't always have access to the patient's chart. I know here at Nebraska Methodist, we have Iowa clients, and I definitely don't have access to those records, so I'm always calling. But it's something as simple as, if it's LIS, it is tech, if we can make our forms accommodating, it'll make our lives easier, and I think it'll be better for the patient as well. I mean, at KU, they changed one thing. They added the ability to add androgen therapy to the rec. They added a designation other than female or male to the chart. If you give us those options, it tells us a wealth of information in one simple change.
That sounds very true.
Some of the stuff that we've seen at Vanderbilt are changes. Again, we don't have androgen therapy as a check mark yet, but in our EPIC system, for, again, those patients who are not, outside clients sending things in, we do have different options for transgender and cisgender patients. So that has sort of helped in our scenario. Again, when they come from our particular transgender clinicians, it's very helpful. But as a growing institution, you may be adding people and, may not be aware of new clinicians as well. There's a couple of papers, one included from the cohort at Vanderbilt, that talk about, different changes we could do to the EMR. And I think they may have talked about that a little bit in one of the ASC podcasts with Dr. Compton. So a little promotion to go check out the ASC podcasts on the website as well.
Sounds good. No, you're absolutely right. I think a lot of things that we kind of struggle with on a day-to-day basis could be really helped by a robust EMR and the way that to kind of put the patients in and get the informations out. And so I guess we'll have to make sure that the ITs of the world and the people who develop these EMRs, they are cognizant of a lot of details that may not seem important to the general idea of an EMR, but it would be really helpful to day-to-day practice, and it would be really helpful to the patients that we serve, because at the end of the day, that's what we are striving to do the best. So I guess it will be a multi-faceted work, and hopefully we get the people in the right places on the right calls, and that would be done. But other than that, I think just knowing about it, just being, inquiring about it when you think about it, or when you have an inclination that this may be one of those cases, is something that I think we all should strive for, and we learned from it from you guys, and this was a very, very helpful, at least for me. I'm sure the audience will agree with me, as they didn't have any questions. I think we answered all of their questions, and it just I think that's a great thing. I will take it as a compliment.
Thank you for your guys' interest. This was of all the projects I did during my training, both at Minnesota and in KU, I think this one was one I felt particularly proud of, because I felt like I was actually accomplishing something very good.
Yes, as you should be. Yes, it was very good. And we also are very thankful for your participation, because it's really helpful when the authors join us in these discussions, and it will give a different level of interaction and understanding of the topic and the discussions.
Oh,
thanks again.
Melissa says, I think her internet went out, so we lost her.
I think so too, because she just vanished from the face of the things, but it was the right time. That's okay. We are very close to the end, and since we don't have any other questions or anything else, I think I will just end it with thanking again both of you, and Melissa hopefully hears it later on, and also saying happy holidays to everybody who is here with us, and wishing for a healthy and peaceful new year to come for everybody.
Thank you.
Have a good one. Bye.